When you think about treating allergies, you probably think about blocking histamine, but there's a new kind of medicine that works differently. It acts inside the mast cell. In this episode, we're talking about BTK inhibitors. You'll learn what BTK is, how these inhibitors work, and what this means for people living with chronic spontaneous urticaria and possibly other allergic conditions. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank Novartis for sponsoring today's episode. While they support the show, all opinions are our own and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now let's get to it.
You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology.
So today we have Dr. Matt Giannetti, and I was happy to meet him a couple of weeks ago when we were discussing this very topic, BTK inhibitors and urticaria. And so Matt, would you mind introducing yourself to the audience?
Yeah, thank you so much for having me here. My name is Matt Giannetti. I'm an allergist and immunologist by training. I practice at Brigham and Women's Hospital in Boston, Massachusetts, and I'm the associate director of the mastocytosis clinic there. So my clinical practice consists mostly of seeing patients with mast cell disorders, including clonal, and then the non-clonal disorders such as urticaria as well.
Great. Thank you so much for joining us. So we are going to be talking about something called BTK today, and I'm not going to pretend to know what that means. So can we just jump off by saying, Dr. Giannetti, what does BTK stand for, and why are we talking about that today?
Yeah, so BTK stands for Bruton's tyrosine kinase. So this is a protein that is one of the final steps in mast cell activation. So when this protein gets activated, if you will, it sends a signal into the mast cell that allows the mast cell to activate and degranulate it. So it's one of the final steps of mast cell activation. And for that reason, it's really important when we think about mast cell disorders and mast cell activation more generally.
We've talked a lot about mast cells on this podcast. That's like one of our favorite cells to talk about, of course, as allergists. And so when we're talking about degranulation, we're talking about the release of all of those chemicals inside of the mast cell. And the main chemical that we're talking about there is histamine, which causes those hives that we're trying to prevent from happening. And what's really exciting is that we actually just got approval for a BTK inhibitor just 2 days ago that is approved for chronic spontaneous urticaria. So this conversation is happening right at the right time. And I'm really glad that you're on, Matt, to help us understand BTK inhibitors a little bit better.
Yeah, it's a fortuitous timing. The medication remibrutinib was just approved 2 days ago. So it's a good time to learn about BTK inhibitors and mast cells in general. BTK is a tyrosine kinase. So remember the name is Bruton's tyrosine kinase. So a kinase is a name for an enzyme that we have in the body. We have many different kinds of enzymes, and they phosphorylate other proteins. So it's a little bit of a complicated topic, but let me try to make an analogy here. So a phosphorylation means putting a phosphorus molecule on a different enzyme. In this context, let's think of it as turning it on. So what BTK does is it flicks a light switch and turns on something downstream. Phosphorylation is really a lot like an on-off switch, and it's an on-off switch that can be used repeatedly by the body as a way to propagate information or convey activation or lack of activation. And that either changes the structure or causes it to be activated or has a whole variety of different physiologic functions, but changes behavior of other enzymes. So what BTK does is when it gets activated, it phosphorylates other things, which leads to a cascade of events, ultimately resulting in mast cell activation. BTK is kind of an interesting target because it's kind of the final pathway before mast cells get activated. So mast cells can integrate signals from a lot of different ways. And if you can block the thing that happens right before they get activated, you can shut down many things that occur beforehand. So it's a really nice way of blocking the final step of activation, thereby blocking mast cell activation.
So BTK inhibitors are basically stopping things. So you're not even letting the chain of events happen when you're using a BTK inhibitor. How does BTK get activated? It's just part of that chain, right?
One primary way, and one way that most people understand, is IgE-mediated mast cell activation. Okay, so what is IgE? Probably you've covered it a little bit on this podcast, but IgE is an antibody that drives allergies. So if you're allergic to penicillin, you have IgE to penicillin. If you're allergic to cat, you have IgE to cat. And if you're allergic to birch tree pollen, you have IgE to birch tree pollen. So you have this IgE floating around in the body, and the mast cells have these really cool little tendrils that stick out into the blood and grab the IgE, and it sticks on the surface of the mast cell. And when you inhale pollen, or when you go over to grandma's house who has 3 cats and you inhale some cat dander, that goes up into your nose, the IgE recognizes it, and it sends a signal into the mast cell to activate the mast cell. This signal is very complex and involves about 10 to 15 different steps. Truthfully, it's a lot more than 10 to 15 different steps. But one step at the end involves BTK. So think of it like a big funnel. If I'm pouring, I don't know, I'm Italian, so pasta sauce into a glass jar to can, you pour the pasta sauce in there, and you can have a big, huge pot of pasta sauce, but it all goes down a funnel centrally. Think at that most narrow point of the funnel is where you have BTK. Now, if I blocked BTK, none of that pasta sauce is going to go all the way through, right? So this is where a BTK inhibitor comes in. Conceptually thinking about it again, you have a lot of things that communicate mast cell activation, IgE, whatever it may be, but ultimately, this leads to a signal in a very narrow point where you have BTK, which is critical to move on to the next step. If we inhibit BTK there, that mast cell never goes on and gets activated. So the concept here is whether you're allergic to cats, or whether you're allergic to dogs, or whether you have hives, all of that can be inhibited simply by blocking BTK, because that's the final point before mast cell activation. The main purpose of BTK inhibitors is it doesn't matter what happens outside the cell, it still blocks it. When we talk about BTK, we're talking about it inside the cell. So it makes BTK inhibitors kind of attractive because there can be a lot of stuff going on outside the cell, but if you're blocking it inside, it doesn't matter really what the noise is outside. You've kind of blocked the common denominator.
So what we're talking about is we're talking about BTK inhibitor. Can you explain to us what you mean by inhibitor? What is it doing in the body exactly?
Yeah, this is a super important question and kind of gets to the heart of how the medication works. So, the concept here is really important. So, I'm going to try to explain it via an analogy. So, BTK you can think of as a protein that's kind of floating around in the cells. And a BTK inhibitor goes to that BTK and grasps onto it covalently and bonds it. So, what that means is it's irreversible. Once it grabs it, that BTK is done. That BTK does not work anymore. And so the BTK is fully inhibited. One molecule of medication will bind one BTK. So the more BTK inhibitor you give, the more ability to BTK to bind. This is why the dose is really important. If we give too much, we're going to bind all the BTK and all of the other cells. But if we give not enough, you're still going to have a lot of BTK floating around in order to activate the mast cells. So it's very much a kind of finding the right dose, finding the right amount in order to do enough good stuff, but not enough bad stuff.
Do you mind if I quickly try to summarize what we just talked about? Because I feel like we just threw out a lot of really wicked terms. I'm saying that because you're in Boston, wicked. And I feel like you can get lost really easy right now. And I'm feeling a little like, okay, I need to stop and understand. So what I'm understanding is that BTK is something that is found in the mast cell, but it's also found in other cells in the body. What it does with the mast cell is it basically tells the mast cell to release the chemicals. So there's a chain of reaction that happens to get the mast cell to release its chemicals. So there's a lot of different things that need to happen in your body before it goes, histamine's released. BTK kind of comes at the last phase of that chain. So you're blocking something kind of at the end of this chain before the mast cell releases. So that's the first thing that we talked about. And then the second thing that we're talking about is blocking this BTK. And that's the BTK inhibitor. The thing about it is because we already said BTK is found in a lot of other cells, not just the mast cell. The question is, well, how do we block just BTK in the mast cell and not impact the other cells that need BTK? Because your body still needs it in those cells, in the other cells, but you don't necessarily need it or you don't want it to be so active in the mast cell. And so what you're saying, Dr. Gianetti, is that with this new medication, remibrutinib, they've been able to say, okay, X amount of BTKs are in the mast cell and X amount are in the other cells. It's lower in the mast cell, so if we are able to block that number that we find in the mast cells, it's not necessarily going to have a long-term big bad effect in the other ones because they're still producing enough BTK for that cell to do its job with the BTK. Does that make sense? Have I kind of understood what we've talked about in the last couple of minutes?
That is perfect. I want to have one additional caveat here. The picture is a little bit more complicated than just quantity in the B cell and the mast cell. There are things like how much of the drug gets into the cell. It may be different for a mast cell than a B cell, how quick the cells resynthesize or recreate BTK. So the story is a little bit more complicated, but conceptually, I think it's an excellent capsule summary, I would say.
And what we know about BTK is that it is found in a lot of different cells and that it's already being used in cancer treatment. And it also has an association with another disorder that's an immune deficiency. So, Matt, do you mind going into that and helping us understand that a little bit better?
BTK is not only found in mast cells, it's found in a variety of cells, although almost exclusively immune cells within the human body. When you're thinking of making a drug or designing a drug, this is one of the challenging aspects because you want to inhibit BTK specifically in mast cells so you can block mast cell activation in hives, but you do not want to inhibit BTK in other cells because, well, that will lead to more side effects and potentially adverse events and things that are not desired by the pharmaceutical company and by the patients. So one of the important things about BTK and actually how it got its name was there is an immunodeficiency that children can have. It's an inherited inborn immunodeficiency called Bruton's A-gamma globulinemia. So this is kind of a big long word, but A-gamma globulinemia is a fancy way of saying you don't have immunoglobulins. So these are little Y-shaped molecules, IgA, you may have heard of IgG, IgM, or IgE in the case of allergies, that target different cells or invaders or pathogens or many different things. And as it turns out, if you have a congenital absence, meaning you were born without BTK, your body has an inability to produce immunoglobulins, which leads to a very severe immunodeficiency. So this is obviously problematic. So the challenge is giving enough BTK inhibitor to inhibit the mast cells, but not cause side effects based on the quantity of BTK found in other cells. Now, there's a couple different points here. So one is specificity of the medication. So that refers to the drug's ability to bind BTK. BTK is the same protein, whether it's in a mast cell, whether it's in a B cell, or whether it's in a different immune cell. Remibrutinib is very specific at binding BTK. It does not bind other things such as TEC, TEC, BMX. These are all kind of like word soup, but non-BTK tyrosine kinase proteins. So you want a drug that's very specific. The second thing is about the quantity of BTK. So if you can imagine a mast cell has 10 units of BTK. Now I'm making these numbers up, but conceptually I think it's a really important framework. So if a mast cell has 10 units of BTK, you want to give enough medication to block those 10 units. Now B cells, for example, have much more than 10 units. They may have 50. So the goal of designing a drug and dosing the drug is getting something that's going to inhibit between 10 and 50 units, i.e. enough to block the mast cells from activating, but not enough to cause B cells from producing immunoglobulins. So it is kind of a fine line that you're trying to thread. And we appear to have done that very well with remibrutinib based on the side effect profile, I would say.
So you need to find the right dose because every dose has so many molecules that will stop so many BTKs. So you don't want a high dose because you don't want to stop all of them. You don't want a low dose because you don't want it to not work. And basically what this medication is doing is it's finding those BTKs that are floating around, attaching to them and never letting go and not letting them do their job.
That is exactly correct. And I would say the follow-up to that, which is really important, is the way these medications wear off, if you will, is the body generates or makes more BTK. Think of it like a little claw machine, right? So you have a bunch of BTK that you're trying to get. Once you get this claw, it comes down, it grabs the BTK, and if you're good at it, then it removes the BTK. And once that BTK is removed, it's gone. It's no longer functional. It's bound to the medication. And then the body generates more things for the claw machine. This is a little bit conceptual, I guess, but then it generates more. But, once that BTK has been bound, it is no longer functional. So we call this generation of new BTK the resynthesis rate. And this is what dictates wearing off of the medications. As opposed to many other drugs, they bind temporarily and then disassociate or get metabolized or broken down. BTK inhibitors work in somewhat of an unconventional way, different than most medications we have, I would say.
And one thing we haven't really touched on is, are these medications injectable medications or oral medications?
Yeah, all BTK inhibitors are oral medications. So, with the specific one that was approved in the allergy domain, remibrutinib, it is a twice daily oral medication, no injectable options. That's good and bad, I would say. I mean, sometimes the once a month injection is nice, but most patients generally prefer oral medications if they can get away with it.
So, what we've really talked about is that BTK is involved in a lot of different things in the body. And when they've studied BTK inhibitors for oncology, they were looking at a different type of dosing, a different type of molecule. And now, this new one that has just been approved for chronic spontaneous urticaria in the allergy space is a totally different molecule than the one that was being used to inhibit the BTK in cancers. With that being said, the main point of all of this is that it is inhibiting the release of the chemicals that cause symptoms from mast cells. And that's really the main thing that people should understand is that there is a chemical that is in many cells, but specifically also in mast cells that allows us to block the chemicals from mast cells from being released. And in this case, we see that it works for chronic spontaneous urticaria. Matt, I know that it's also being studied in other allergic disease. Can you speak to what other allergic disease it's being studied in?
Yeah, this is a good question. So, as a mast cell biologist, I study and research and treat patients with all kinds of diseases of the mast cells. Almost all of them are diseases of activation of the mast cells. So, in my world, we're trying to stop mast cell activation or decrease mast cell activation. So, if you think about allergic disease, I have this really cool slide when I give a talk. It's a slide from Jem Aiken in 2010 where it shows essentially all of the mast cell activation disorders. But if you think of a general allergy clinic, 90% of the disorders in there involve mast cell activation. So allergic rhinitis, itchy watery eyes, sneezing in the spring, that's a mast cell activation disorder. Food allergy, a little kid eats a peanut and has anaphylaxis, that is a mast cell activation disorder. We've talked about hives. Allergic asthma, so people when they're allergic to pollen and they have wheezing and coughing and sneezing, that is also a mast cell activation disorder. My particular area's interest is mastocytosis. It's a clonal or cancer-like disorder of mast cells. The common thread for all of these disorders is that they all involve uncontrolled or more activation of mast cells than we would like. So having a tool like this is really cool. So it is absolutely being studied for many of these other disorders. There's in fact a clinical trial ongoing for a different BTK inhibitor right now in mastocytosis. I can't speak to plans of any pharmaceutical company, but for sure this is going to be looked at in food allergy and in allergic rhinitis. So I think this has a lot of potential to really revolutionize how we treat mast cell activation disorders. These types of medications will be used more broadly in mast cell disorders in the future.
I don't know. I guess I'm like fascinated at this idea that it's just kind of like stopping the mast cell from releasing its chemicals. So to me, it just sounds like it's going to like impact a lot of allergic conditions, but I don't know.
It will. Yeah, it'll totally ablate your pollen allergies and food allergies, truthfully, too.
I think that this is the early days of BTK inhibitors, and we'll really have to see what other conditions it's going to be approved for. And so I do think that BTK inhibitors will be approved for other conditions because we understand the mechanism, we understand how to safely give it to patients. And that's the next thing that we really want to touch on is the safety of these medications. We've kind of alluded to it a little bit, but I just want to dive a little bit deeper because, as I mentioned, this is a new mechanism of action for allergists, dermatologists. And I think a lot of people, because of that BTK disease that you mentioned before, they are worried about what it's going to do to the immunoglobulins. And then there was also some mention of petechiae, which was something else that people were worried about. So can you talk a little bit about all of those things?
All of the data that I've seen so far highlights these as really incredibly safe options. We've looked at immunoglobulins after 1 year of consistent taking the medication, and we have not found any differences. So there doesn't appear to be any signs that we're causing an immunodeficiency. Now, I would say there's still a couple caveats. Some patients with quite severe hives are on omalizumab for a long period of time, often many, many years. We have not had humans exposed to BTK inhibitors for that long duration of time. So while it looks quite safe now, I do think there's always potential for things to change and we should monitor the longer term side effects. But at least for short term control, they look safe. The other thing you mentioned, petechiae, we should stop a second and say, what are petechiae? So petechiae are like little bruises. You tend to get them on your lower extremities. What they are actually is little burst blood vessels. So it looks like reddish brown. And much like a bruise, if you push on it, it does not change color. So think of them as little tiny, tiny bruises, like the head of a needle. Why this happens, there's a variety of reasons it can happen. But at the core, they're little burst blood vessels. So BTK is also expressed in platelets, as it turns out. And platelets, I'm not sure if we've covered them here, but they are things that are responsible for blood clotting. So probably we're seeing a side effect as a result of that. These aren't, particularly bothersome. They can have some cosmetic appearance, but as long as they're in small quantities and resolving, I'm not sure that I'm super concerned about this, but it is something that, again, will need to be observed over longer periods of time, over more people on the medication, and make sure there's not something that we've missed about this.
And as I always say, the more the merrier. I'm really excited to have another treatment option for patients with chronic spontaneous urticaria because I see it really often in my clinic, and we'll use shared decision making. If the injectable medications aren't really where they want to go, they might start with something like the oral BTK inhibitor, and then we can go from there. And I think the other nice thing is that these medications do work pretty rapidly, right? So if it's going to work for you, they do work pretty quickly in getting your symptoms under control, which is also really nice.
Yeah, I completely agree with that. As a human who also has hives, having medications work pretty quickly within a week or so is a very valuable aspect of the medication. So definitely a good thing.
Great. Well, thank you so much, Matt, for helping us dissect this complicated topic, at least explain over a podcast. Sometimes pictures are really helpful when you're talking about these topics, but you did an awesome job at helping us understand what BTK inhibitors are and trying to help us paint a picture as people are taking a walk or running or whatever you're doing as you're listening to this podcast. Hopefully, you understand BTK inhibitors a little bit better, and we will have some other images and things like that are available on the website that you can refer to also see exactly what we're talking about when we're talking about BTK inhibitors and how they're stopping the chemicals from mast cells from being released. So I don't think this is the last we're going to hear about BTK inhibitors. I think that they're going to be around for a while with allergic disease. So thanks again for being on the podcast and helping us understand them better.
Yeah, thank you, Pyle, Courtney. My pleasure. Thanks again for having me.
Awesome. Thank you.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.